So we divide things up into simple aspects. Now I said to you, I've used the example of the hip being the easiest one when we're looking at orthopedics, because so either things can present in either traumatic presentations or elective presentations. The traumatics are usually fracture, dislocation, infections, or other things. Elective in the hip, is arthritis or bursitis, or referred from the back, and that's about it. So labral tears are really part of the progression of arthritis that leads to the arthritis. So really, the hip's the easiest one. Hand and wrist is probably the hardest one, okay? You've probably been down to clinics and you think, geez, they didn't take a full-on history and assessment of that hand. Often you can't, because often you haven't got time, there's a busy clinic, and really you need to divide up into subdivisions of the hands to make it a bit easier to work things out. What I mean by that is I'm going to use my rule of threes to divide up. Remember my rule of threes we talked about before, okay? So how do things present? They either present traumatically or electively. And when we're taking a history to help us form our diagnosis, we use the history to help us divide to assess the patient. So the most important aspect of assessing a patient to determine the diagnosis to the history. Examination helps confirm the diagnosis, and the investigations help us stage the condition, determine treatment options, and determine prognosis, right? So our history is what helps us form the diagnosis. Okay, and we divide the history up into how the patient may present to help us remember what the conditions are, traumatically or elective conditions. The traumatic conditions are up on the board there. We fracture, dislocation, and infections. Okay, we'll go through those in a second. The elective conditions, well, they're more can be divided up into areas. You need to, for elective, for most times, you need to try and work out the main conditions that can occur. And as I said, hip is arthritis or bursitis. Shoulder will go into it in a little while. The rotator cuff conditions, or frozen shoulder, or arthritis, or referred from the neck. That's really all there is in the shoulder. We'll go into it in more detail on Tuesday. But for the hand, there's so many different areas. So I divide up into three main areas. Okay, they can be basic neurological conditions, tendon conditions, or bony conditions. We've obviously got soft tissue ones too, which are really the odd ones out that fit into it. There's 3 or 4 main areas. Okay, and we'll go into that more in detail. So it comes down to fractures. Now you need to know your anatomy too when you come to assess any area of the body, but nothing more so than in the hand and wrist. Okay. Alright, so you got to remember, and we just look at our own hands, the anatomy is there on display, okay? So before we go down the fracture, dislocation, infections, or the elective presentations, let's remind us of the anatomy. Okay, we look at your wrist, okay? If you feel across here, and you start off on the radial styloid. But if you actually feel the radial styloid, that hard bone there on that radial styloid is not actually the bone. You're actually feeling a bunch of tendons which make up the first extensor compartment. How many extensor compartments are there in the wrist? Do you know? There's a whole bunch of tendons that go across the wrist, and there's 6 different compartments. Divide those tendons into little compartments. The first involves the abductor pollicis longus and extensor pollicis brevis. Then you've got your second compartment with extensor carpi radialis longus and brevis. Third compartment is extensor pollicis longus, which cuts around the listus tubercle, which is on the dorsal aspect of the wrist. Fourth involves the extensor digitorum communis and the extensor indicis. Okay. Fifth is extensor digiti minimi, and sixth is extensor carpi ulnaris, which is actually an important stabilising structure for the distal radial ulnar joint. So a little bunch of tendons across there. Okay. So knowing those extensor compartments, you don't have to know all the tendons in it, but if you can actually think of the extensor compartments, is useful. But knowing that tendons can get trapped in compartments can lead to tendinitis is also useful. Okay. So pain along the radial wall of the wrist doesn't always have to be a fractured scaphoid. It could be inflammation of the extensor tendon. Okay. Just deep the extensor tendons is a radial styloid, and across the top is a dorsal radius. Okay. Going distally, we all know the anatomical snuffbox. But in the snuffbox is right at the base of it, proximally is a radial styloid. Then you have a scaphoid, then you've got a carpal metacarpal, your scaphotrapezial joint going to the carpal metacarpal joint. So any of those areas of the bones can be broken in the wrist. Okay? And you get pain there. Going across slightly radial, so onwards is the scapholunate ligament, which is an important connecting structure of the 2 bones of the proximal radial of the wrist. And then you get across to the distal radial ulnar joint, where supination and pronation occur, and you have triangular fibre cartilage. So it's worth just going home and looking at anatomy again. Then you got your carpus bones, okay? So you got your 8 carpal bones. Okay, who's going to go through the carpal bones? Okay, let's go through them one at a time. How do you remember?
The connects on those strike positions that I can't
I haven't heard that one. So what are the bones?
Scaphoid, lunate, trapezium, trapezoid, then triquetrum.
And so
Scaphoid lunate, triquetrum, pisiform, trapezium, trapezoid, captate.
yeah, exactly. So, and the pisiform triquetral joint, the pisiform actually sits anterior. So if you go and bump something, or you hit something on the, often if you're trying to push something into it, and you do that movement like that. I think this actually might be a karate position as well, I'm not sure. But anyway, if you hit something like that, you're actually hitting with the pisiform, and you actually fracture the pisiform. Well, later on you get arthritis of the pisiform triquetral area, so that can be pain on that side of the wrist. Okay. The triquetrum is the ulnar-sided carpal bone, just so you escape the main ones, because the pisiform's sitting anteriorly, scaphoid lunate triquetrum. Okay. Triquetrum is where ligaments attach to it, and when you get a sprain to your wrist, that's where ligaments can rip off, and with a fragment of bone. So often you see a triquetral fracture there. It's really just a bad sprain. Okay. Then we've got, so they're the 8 bones, and they're the important things to know. Scaphoid lunate is a drive shaft of the wrist that connects the proximal row together. The triquetrum is where the extrinsic ligaments attach. There's lots of extrinsic ligaments. They go attach to lots of areas, but that's the main one that avulses when you have an injury. So you might see someone who's sprained their wrist and taken off a little bit of bone. You might get pain in the pisiform triquetral area from arthritis or from a fracture. Or you could just get a fracture of the other carpal bones. So a classic one is someone who falls or a punching injury and they get pain at the base of the 5th metacarpal. The 5th metacarpal can subluxate dorsally and takes away a little corner of the hamate as well, which is a stabilising structure. So just think of the injuries that can occur around those areas. So then we come down to our metacarpals and our phalanges. So the main things that can be fractured or injured, the common things that need to be aware of after an injury is maybe a fractured wrist, which includes the radial styloid, okay, a fracture of the ulna or disruption of the distal radial ulnar joint, okay. So Galeazzi type condition, where it's called Galeazzi, with the distal radial ulnar joint disrupted. You get a fractured scaphoid. What's the main problem with the fractured scaphoid? That's what everyone tells you. It's like the main problem with the hips, avascular necrosis. But the main problem is that the bone needs to heal. Okay, it's getting the bone to heal. If it doesn't heal, then you disrupt the drive shaft of the whole between the proximal and distal rows of the carpus, and that leads to early arthritis. One of the reasons it doesn't heal is the blood supply is poor, and it can develop avascular necrosis. Bones that develop avascular necrosis, as long as they revascularise, they're fine. Okay, so avascular necrosis, the thing that everyone worries about, it's actually more about in the bone to heal. Okay, so you need to know about the high risk of avascular necrosis, but that is because it may lead to the bone's not healing, and then to secondary arthritis. So the main thing is the low healing rate of a scaphoid fracture. Okay, all right, and that part of that is because of avascular necrosis. What affects vascularity? Blood supply, that's right, and it's because the blood supply is unusual, it comes in distally, more in the scaphoid. And what affects blood supply? What can you do to stuff up your blood supply in your wrist? Yeah, smoking, yeah. So smoking can affect blood supply. Leads to vascular squeezing of the vessels, okay? Ischemia. So there's other things too, like blood disorders and things too, like sickle cells and things like that, but smoking is the most common thing, okay? Other causes of avascular necrosis can be steroids and things and alcohol, but really for scaphoid fracture, it's blood with smoking. So we've got those fractures that can occur, okay? When you come down the wrist, you've got fractures of the metacarpals that can occur, okay? The base of the first metacarpal can lead to Bennett's fracture, okay? And it's if you have an injury where your thumb is pushed to the side or is hyper-abducted, you can actually try and dislocate your thumb, and there's a little fragment of bone sitting with ligaments attached on the ulnar side, and that's a Bennett's fracture. Okay, or you can just have a fracture of any of these metacarpals can be distorted. Another classic one is if someone punches something. Often you see them punching a wall, and the fracture of the metacarpal. The wall never comes in for some reason; it gets treated, but the hand comes in. Okay. If, however, you punch someone in the face, okay, and don't try this at home, but if you do, and you get a tooth mark on the metacarpal head, that's because a tooth has to go through and hit something, and it hits the bone. And in hitting the bone, right at that spot is a joint, and a tooth with lots of bacteria hitting the joint is a great way of getting a septic arthritis, the metacarpal phalangeal joint. So if someone comes with a punch injury to their face, if someone's punched someone in the face and got a tooth mark on their metacarpal, that just needs washing out. It needs to have surgery to have it washed out. It's not something you just stitch up and send home, or put them on antibiotics. It needs surgery to have it washed out. You'd be surprised. It was quite common, of course, but it's actually because most conditions, I mean, I know you see Jason Bourne the moment he gets shot, the most important thing for him to do is stitch it up. But most times the best way of actually treating a potential infection is the opposite, is actually to Hibernate, we'll come back to it later. The most ways to treat a infection is actually leave the wound open and wash it out. So Jason Bourne, instead of actually sewing it up, you're better off opening it up more. So, but that doesn't make good movies. So the same thing with the hand. The last thing you want to do if you have a punch injury is to actually sew it up and put them on antibiotics. You want to leave it open. In fact, if anything, take it to the theatre and wash it out further. Okay. So we got our fractured styloids, wrist, distal radial ulnar joint, got our scaphoid, our base of our thumb. We have our carpus. We got partial triquetral arthritis, and you get metacarpal fractures or phalangeal fractures. And I used to give this talk in the United Kingdom to GPs, and I'd say to them, about the different fractures, and they say, well, is there any point X-raying a hand because you never operate on a hand? Because I don't know who told these GPs this, because if you get deformity of the fingers, it can lead to quite bad functional deformity. So a hand surgeon was mortified to hear that you'd not operate on a hand if it was actually a bad fracture. So an X-ray is useful because there's often simple fractures like a punch injury with some angulation of the fifth metacarpal, we might treat that conservatively. But if there's angulation or rotational deformity, or if there's hyperextension in one of the phalanges, that can lead to weird cosmetic abnormality or functional abnormality. So you want to store anatomy as best you possibly can in most cases, particularly around the hand when you're using it for fine movements. Okay, so I'll just come back to get my slide back open. Here we go. So we can see up there. So they're ones to talk about in general, and I'll try and put this talk online. But really, I've written down the scaphoid fractures, the other carpus bones, which can either be the pisiform or the triquetrum, which can be avulsed. Okay, we've got our phalanges, our metacarpals, including the Bennett's fractures, and the distal radius. So they're the main ones to know. You need to know about falling outstretched wrist. You could fracture your radius, you could fracture your scaphoid, and there are other areas that can be damaged. Okay. Then we've got our dislocations. Okay. Now the most common dislocation you get around the hand would be one of the phalangeal PRP or DRP joints, usually the PRP joints from a hyperextension injury. So if someone's fallen while playing footy and they come off the field and their fingers distorted, the first thing the trainer will do is reduce it. Okay. The second thing they should do after they finish the game of footy is go and have an X-ray to make sure there's been no fracture associated with it as well, not just reduce it and then get on for the next training session and play footy the next day. Okay, they need to make sure there's nothing associated with it. Okay.
So, are you saying that it's fine if someone dislocates their finger to pop it back in?
The best, if anyone dislocates any joint, if you've got permission and it's appropriate and you're trained enough, the first thing you want to do is actually get the thing back in the joint, because for a few seconds they're pain-free. So you actually want to get it back into joint as best as possible. So you probably dislocate your shoulder, but in a few seconds, if you get it back in straight away, it's easy. After a few minutes, it goes into spasm, and that's when it's really hard. Okay, and then if in that situation, they put a ring block. But if you go and sit on a footy field on the sidelines of a footy ground, there'll be people coming off all the time who've got dislocated fingers. It's a really common scenario. I would say, working in a sports scenario, it's a very it's a different way of thinking. Like, for years, in fact, they probably still do it. People break their ribs and they go and have an injection of local anaesthetic, so they go back and play on the game. You wouldn't do it to horses. A horse has an injury, they inject local and let them run the main race at the Melbourne Cup. But footy players, they get injected with local in different areas and they go on back in and play. So it is a different way of doing it. I think it's probably becoming a bit more. People tread more carefully, but there's a case only of 10 years ago where someone had an injection of a local in their rib and then developed a pneumothorax afterwards. So certainly the sports doctors, and Terry will tell you about some of the ways the sports are injured, injuries are managed, but certainly for some conditions they use local anaesthetic to keep them playing. So when you see someone come off at 3/4 time during a grand final and say they're back playing, you know what's happened in the halfway through during that 3/4 time break. So unusual way of thinking, but for most, if you fell over right now and dislocate your finger, right, and you're happy for me to do so, the best thing I could do is actually reduce it straight away for you. I then send you down and get an X-ray and see if there's anything broken, and then manage it from there. But a quick reduction initially. If you waited 5 minutes and came to see me, I'd put some local around your finger, put a ring block in, and then do it for you. Okay. But if you do it within seconds, you've got a pretty good chance of getting it reduced. And it's the best thing you can do for pain relief too is getting the joint reduced. You know, everyone, I don't know if anyone's ever had a dislocated shoulder, but I've not had one, but people in absolute agony, and then you get it reduced and they're pain free. Which is why when they do a reduction under sedation, you know, they're giving a lot of pain relief to get it reduced. And in casualty, the most important thing is to watch them once it's reduced, because suddenly the pain stimulus is gone because it's suddenly the shoulder's pain free. And if you've got that morphine or fentanyl running around the system, if you're not careful, it can actually then make them sedated and do some respiratory reduction. So you got to watch them afterwards. Okay. Yeah, but there's unusual sports injuries. It's a different way of thinking. So it sounds good being a sports doctor, but you've got to, you know, it's how you act in the way that the other peers act as well. But there is it's a very different way of thinking then. You know, you've seen the Tour de France people, they fall over and break their clavicle, and 2 weeks later they're riding. You know, if you broke your clavicle, I wouldn't be recommending you riding a bike. But that's what they do, because it's a different ball game in that sort of area. So we've got our fractures, like dislocations. Okay, so the dislocations that occur, as I say, PRP joints. Other things you need to be aware of is fractures, is dislocations around the wrist. Okay, so they're pretty rare, but one of the serious and one of the orthopedic emergencies would be a fracture dislocation of a distal radius. So the carpal radius, so like say a perilunate dislocation, where the carpal bones dislocate either away from the lunate, or they dislocate away from the lunate, and then as they reduce, the lunate is pushed dorsally out, so the lunate is dislocated. And that is picked up on if you look at x-rays on a perilunate dislocation, you look for the 4 C's on lateral view. So basically you need to look at the radius lining up with the lunate, which lines up with the capitate, which then lines up with the metacarpal, and it's called the 4 C's. And you need to look for a bone that might be sitting outwards or dorsally. So I always remember as a registrar, a lad who was in a lot of discomfort, and because of his pain, it was being quite abusive to the staff, and the staff, I think, were not taking to him too kindly. And anyway, I took him aside and had a look at him, and his wrist he'd fallen off a wall. We'd been standing on a wall and fallen and directly on his hand. And I thought, gee, this doesn't look quite right. And I took him around to get x-rayed, and he had a bad perilunate dislocation, and it's sort of one of the ones you want to get on and get treated straight away in a young lad. It's very painful, but also can lead to avascular necrosis of the lunate, of some of the lunate or some of the other carpal bones around it, because you're putting pressure on that, and also puts pressure on the nerve, the median nerve, which is sitting there. Okay. So, for things to know, for fractures, the main bones, dislocations of the PRP joints. A fracture dislocation would be a Bennett's fracture, where it's sublux, or a perilunate dislocation, because it's one not to miss. Okay, so it's an important one not to miss, and knowing about looking at the lateral views and looking for the 4 C's. And that's something you can look up online, look up perilunate dislocation, I'll show pictures of it. It's not common, you know, I think we had one a couple of years ago here, and I can't remember one that's coming, we probably want to get one every couple of years. You know, probably Royal Adelaide Hospital with a major trauma, they'll probably get 1 or 2 a year, but that'd be about it. Okay? It's not a very common thing, but it's one not to miss. Then we've got infections, okay? So infections can involve any area, as I talked about the metacarpal phalangeal joint after a punch injury, or any penetrating injury. Another one, which actually I consider one of the orthopedic emergencies, is the flexor tenosynovitis, where you've got the flexor tendon runs in the sheath up to the fingers. Okay? And if you get an infection involving the flexor tendons, it can lead to pain and reduced movement of that finger, but because it's a tight constrictive area, any infection in the area can block off the blood supply, damage the tendon itself, can lead to adhesions, and also then lead to stiffness of the finger, which, if not treated, can lead to lack of permanent loss of motion of that finger, which is really quite disabling to the person. And that because the tendon of the flexor sheath is so superficial, it just needs a laceration. And I saw someone using steel wool once, and it happened to cut across right at the PRP flexion crease, and it happened to cut into the tendon and got an infection from it. And the treatment is just to wash it out. So one of the most simplest washouts ever is to do a small cut here and a small cut here, and in theatre, wash it out. So, but if you don't treat it within the first 6 hours, it can particularly, it can actually lead to a bad infection, which leads to stiffness and loss of motion of the finger. Okay, so I consider one of the rare orthopedic emergencies. There's half a dozen orthopedic emergencies, and I don't know if have they talked to you about, have you been through that at all yet? If not, then we could grab a. We have to go through. I'll go through that at the end. We'll mention the 6 ones to look about. Okay, but that's one of the orthopedic emergencies. Okay, so infections, and then we've got lacerations, which are a combination of all these things. It's a penetrating injury which can lead to infections, but more importantly, damage to structures. We've talked about the bony structure in the wrist. What are the soft tissue structures in the wrist? We've done our extensor tendons. What's on the flexor side? Flexor tendons, and also the carpal tunnel, which involves, what's in the carpal tunnel? The median nerves, one of the main structures. You've got your main flexors, okay, FDP and FDSs, okay, you've got your FPL, and you've got your median nerve, okay. Sitting outside the carpal tunnel, but also in the aspect of the wrist, is also the Quervain canal, which involves the ulnar artery and the ulnar nerve, okay, which is just volar to the carpal tunnel on the ulnar side. Okay, so you've got two main nerves to the wrist and two main arteries, the radial artery and the ulnar artery. The radial artery is not part of the carpal tunnel, it's external to it. But you've got your radial artery, median nerve of the flexor tendons in the carpal tunnel, the ulnar artery and ulnar nerve in Quervain canal, which is a little sheath outside the carpal tunnel. So if you cut across there, you can damage all those structures. Okay, it's what's known as a spaghetti wrist, because you've got so many tendons damaged in the arteries. Quite a serious injury. Okay. Ironically, probably the blood loss factor is the least of the person's concern. Okay, you can bleed to death from cutting those two arteries, but they can also be controlled fairly easily. But cutting the nerves are more serious, and they can lead to permanent damage if they can't be repaired. Okay, so it's not a good thing to do. Okay, and then we've also down the palm, we've got our palmar tissue and a palmar fascia, which can lead to contractions, lead to a condition called Dupuytren's contractures or Dupuytren's disease. Then we've got our flexor tendons, and we've got our nerves and arteries as well. So we've got our bones, our soft tissues, and our tendons and nerves. Okay? So laceration can involve any of those areas. It can damage tendons, it can damage nerves. And the problems with tendon damage is that because they require a lot of force to use your tendons, you need to get them repaired quite quickly. Otherwise the tendons, because the muscle contractures, can retract and make it hard to repair them. So when you see a person come in with a traumatic presentation in the hand, what we're looking for is basically what they possibly could have injured. Could they have injured bones? Could they have damaged soft tissues by the penetrating injury or torn soft tissues? Could there be a laceration to the area? Okay? And these are the things to look out for. Okay, we'll go through the examination of that part. Electively, which is one of the things you might see more in a exam scenario, it comes down to the four main conditions. Is it a neurological condition? Okay, so are we looking for, if someone can present with pins and needles or numbness in part of their arm, okay, or is it a tendon condition? Is it pain associated to a tendon? Is it pain along the first extensor compartment or dorsal extensor compartment from movement of the tendons, or is it catching of the tendon like a triggering finger? Okay, or is it arthritis involving the bones? Okay, or other soft tissue conditions? Okay, like Dupuytren's disease or triangular fibre cartilage tear. The triangular fibre cartilage is a tissue that sits on the tip of the ulnar styloid and rotates a radius all the way around. Now, right at this stage, you're thinking, shit. I asked him how much I had to need to know, and he's just given me 20 different conditions. How the hell am I going to remember all this? But it's not that much harder than you think it is. I mean, you just need to know the conditions and what can break. And really, you don't have to know, when I examined young Will's wrist the other day, who was falling over playing footy, I didn't say, well, I did actually say it was going to be the dorsal radius, but I didn't know for sure it was going to be. I've had years of experience to work that out. But I mean, if I said, geez, this could be a break, I need an x-ray, I did well, all right? I actually thought it was going to be a dorsal radial fracture, actually. But that's one advantage of doing 20 years or 30 years of orthopedics. But you don't need to know that sort of level, okay? All right? So, and that's why when we see a neurological condition in casualty in clinic, so when we see a lad being presented and he's got a history of carpal tunnel, or someone says the GP thinks he's got carpal tunnel, we'll go along and take a history, but history focuses on the neurological part of the history. Okay. If he comes along with pain, we're thinking, is it a tendonitis or is it an arthritic condition? And we focus on one of those two conditions. Okay. And if they come along with a more obvious condition like Dupuytren's or soft tissue contracture or pain on the ulnar side of the wrist, we're thinking more of a triangular fibre cartilage tear. So let's put this in perspective. So the the neurological conditions can be, what are the main neurological conditions that can occur in the hand? What can cause numbness in the hand? Carpal tunnel. It affects the median nerve. It's a trapping of the median nerve in the carpal tunnel. Why does it occur? It's because the tendons become enlarged, or the ligaments around the bones become enlarged because of arthritis, and it's only got a little space to go, and the nerve itself, there's actually a photo on my website if you go to look up carpal tunnel, you'll see the median nerve is massive. All the pictures you see if you go down to anatomy, when you're in the anatomy museum, have a look at the nerve. It's actually a good centimetre width, and the wrist, particularly in a lady, which is why it affects probably ladies more often, it's got smaller wrists. The nerve is still really big, and yet the carpal tunnel is quite small. You only need a bit of enlargement of the tendons to compress that nerve. And like anything, there's a way of thinking about it. If you get cross with me and start strangling me, initially I might be a little bit upset with it later on, but initially I might be a bit agitated, right? Okay, and that's like the nerve, and it's being strangled, it's losing its blood supply, it gets agitated, you get this hypersensitivity, you get paresthesia. Okay, if you keep strangling me, after a while I might go a bit quiet. Doesn't mean I'm actually getting better. It might not be good for me, right? And the same thing with the carpal tunnel. The median nerve, as it's being strangled, it slowly dies off. It slowly dies off, and it's suddenly the pins and needles goes away, and people think, oh, my carpal tunnel is better, but it's a little bit numb. What's happening is the nerve is dying. Okay, and just like a strangling, if you let go of me before I stop breathing, I'll probably be not that happy, but I'll probably be okay. Same with the nerve. If you release it at the right time, it recovers. But if you leave it too long, the median nerve can be damaged permanently. So that's why carpal tunnels are better off being treated early if possible, and we try and get them in early if we can in the hospital. Okay. So that's exactly how the nerve behaves. Because really, I'm just a bunch of nerves connected to bones and tendons, really, and we behave exactly the same way. So carpal tunnel, the treatment is to see if the symptoms settle down. There can be secondary causes for carpal tunnel, such as pregnancy, thyroid issues. It can relate to fluid collections and things, or it could be rheumatoid arthritis and all the tendons become inflamed. And if you treat those, it might settle down. It may be a positional, and that's why, particularly during pregnancy, you might use wrist splints to try and stop the hands going into position, and once the pregnancy is over, people are fine. But if not, a release of the carpal tunnel is the way to go. Release the flexor retinaculum, give the chance for the nerve to recover. Okay. Other nerve conditions, though, that affects the median nerve distribution. What affects this side of the hand here? The ulnar nerve. And the ulnar nerve can be trapped in a few spots, but particularly around the cubital tunnel, around the elbow, which we talked about the other day, but also in Grion's canal. Okay. And remember, Tinel's sign is a great way of checking for where the nerve is trapped, by tapping along like the cubital tunnel or the median nerve to see where it's trapped. Okay. Also remembering though that it could be coming centrally. I mean, that ulnar nerve can look just like a C8. Okay, so you've got to remember to check the neck as well when you assess them. Okay. And of course, you can get trapping of nerves in the back of the hand as well. So you can get mechanical trapping, such as you get a Saturday night palsy where the radial nerve's been compressed, or even at the wrist where you actually do a whole heap of studies, join one of these gyms that are doing a heap of weights, and saying you extend the muscle so much that it traps the posterior pterygoid nerve, and that can lead to a palsy of the nerve itself. And you get other weird things that can go on too. I mean, we don't know all the answers. I mean, for some reason, when I get a gastro, I don't know what happens when I get a gastro. I had a food poisoning a year and a half ago after going to cricket, and I got this really bad gastro for 3 or 4 days. I always get really bad carpal tunnel symptoms for it. And actually at that time when it was really bad, I actually got a bit of a slight posterior pterygoid nerve palsy. I couldn't extend my index finger as well. I think that's not good. But it recovered after the gastro recovered. God knows why that occurs. I'm a hand surgeon. I don't know the answer to that. But some strange things going to happen. And that's what the excitement of your career will be, is over your years you'll find out what these things are. Some of these things are. Okay. So that's the neurological side of things. Let's just go back to the So then we come down to cause of the pain. Okay, so painful conditions can be either tendonitis, and a classic one. In fact, actually, I heard on the ABC radio the other day on Saturday. I was just driving somewhere and put on the ABC radio, and they had a really interesting article. It was actually about I think it was like treating a baby or pregnancy things, but there's actually someone talking about the Quervain Tenosynovitis, which I actually I don't think I was ever taught this. I worked it out, but obviously people have also worked it out at the same time. It's actually very common in newborn mums or dads picking up the child, put on the changing table. So you get pain on the radial border of the wrist, okay? And the tendons, because when you're using those movements, the tendons here get inflamed. So actually also those people get people with brand new puppies or something, and they pick up their puppy dog or something, okay? And you get pain on the first extensor compartment, and it's really sore. It's worse when you do this movement like this, and that's called Finklestein's test, when you stretch the tendon. And that's inflammation of the first extensor compartment. This 20-minute radio program was actually a really good summary of how to treat it, actually. They talked about physio and avoiding the movements or using braces, and then surgery as well, and injections. So, but it's actually a first extensor compartment can get inflamed. The same so you can get tendonitis on the back of the wrist. I saw that in one of the footy players once, where a lot of the pain was actually just directly over the wrist. And these tendonitis can be treated with rest, ice, avoiding the movements, steroid injection to help settle it down. And if that doesn't work, then release of the tendons can also be done. But you also can get it involved in the palm. I see it in a lot of musicians when they're playing the guitar or the banjo or something, and the flexor tendons get quite inflamed or they enlarge. They get caught in the pulleys. There's a whole bunch of pulleys that go down the fingers that hold the tendon to the phalanges to allow it to flex. Otherwise, it would bowstring as you pulled on it. It cut across the corner in where to flex it. So these pulleys hold it down. But right here, there's a pulley that can trap a tendon. What happens? The tendon develops in the nodule. A nodule develops in the tendon. Back the other way around, and traps the tendon as it moves, and so you actually get these things called triggering fingers. Now, some people, it's actually congenital too. So you get some children who develop it in their thumbs because the tendons just happen to have nodules on it. But most of the ones you'll see will be more older people as the tendons become inflamed and develop nodules and get trapped in the pulleys. And it's a simple either injection of steroid to help it settle down, but usually a release of the pulley so the tendon doesn't get caught there anymore. You can't take the nodule out because it's the thickening of the tendon. Take it out and damage the tendon, so you release part of the sheath to allow the tendon to move well. And that's called trigger fingers. Okay? It's exactly the same scenario as this tendon here. It's triggering of the first extensor compartment. It causes pain, but this time it actually cuts. So you've got to make a fist and the person will go click, and then they won't be able to straighten and they have to click it open again. So it's like almost like one of those cupboard doors with those sort of the latch type doors that, the hinges. Does that make sense? So it's triggering, okay? But then you get the other main cause of pain around the wrist are arthritis. And you get arthritis in numerous spots. People now think that the most common cause of wrist arthritis is post-traumatic arthritis. So they've either broken their wrist, or they've built avascular necrosis, the lunate, or they have fractured the scaphoid, or they've got disrupted the scapholunate ligament. So primary arthritis of the wrist is not thought to be that common. It's actually secondary to trauma. It's not many of us who wouldn't have fallen over at some stage while playing sport or fallen off your bike while you learned to ride a bike. So most of us have had some sort of traumatic, and some of these can cause go on to develop arthritis. Okay? So maybe in the future, if in an ideal world, if every time we had an injury we could pick it up and treat it straight away, maybe arthritis of the wrist would be really rare. That's an ideal world. So you can get arthritis in the radio if you fracture your scaphoid, or you disrupt the ligament between the scapholunate, that can lead to either what's called a scapholunate advanced collapse, when there's a scapholunate disruption that leads to arthritis more on the radial side of the wrist, or scaphoid non-union arthritis, which is again radial side of arthritis, which affects the scaphoid and radius, and so they develop pain on the radial side of the wrist, right where you think right in the anatomical snuffbox, and so that can be a cause of pain, which is not associated with a fracture directly. So maybe you broke your scaphoid years ago, never had it treated, and later on you get secondary arthritis right in that same spot. Okay, or you damage you break the metacarpal and it subluxes slightly because you leave it with a bone, and it's a Bennett's fracture, and that leads to arthritis of the carpometacarpal joint. Okay, or you break your wrist and it doesn't heal quite correctly, and you get disruption of the irregularity of the distal radial ulnar joint, and it leads to arthritis of the distal radial ulnar joint. Okay. So main causes of pain around the wrist are either tendonitis or arthritis. But being aware that if it was actually a neurological symptoms, again, pins and needles and numbness, that can cause a type of pain, but it's a different type of pain. And the main problem there is pins and needles that's affecting them with a lack of ability to grip things. And they also get pain out their hand. Finally, as part of those fractures, by the way, here avascular necrosis, we talked about the scaphoid. You can get a condition where the lunate just dies off on its own, and that's called Quervain disease. We had one the other day in clinic, but it's quite, you know, probably more common than the perilunate dislocations, but you probably get 1 or 2 a year. It's just unlucky where it can be related to, like any cause of avasculosis, alcohol or smoking or steroid use. But usually Quervain just comes out of the blue. If they are smoking at the same time, it's really important to stop them smoking, although unfortunately it doesn't always have, you can't always influence people to do that, unfortunately. So, and then you get a few other conditions to be aware of too. So Dupuytren's disease, where the contractures is, what causes Dupuytren's? Does anyone know? Does everyone know what it is?
Is it Carpal?
That's what I used to say. That's the reason I asked you that. It's sorry?
Manual labour.
Manual labour. People used to say that as well. What did you say? Trauma. No. Well, actually, I think it can come on, bring it on after trauma, but alcohol and manual labour, there may be some associations still, but really the main reason is genetics. Okay, so I worked in Scotland for 5 years, and honestly, every second person had it over there. It was almost felt like that way. It relates to the Viking genes back in the I think it was 8th century or 12th century, when they came and invaded the United Kingdom and left their genes after the associated shenanigans that went on at the same time, and that's what it's all doing. So it's actually very, very German or northern UK sort of area, the Celtic population. So the ones you see here in Australia, and they're almost always British people, all right, and I think I think it's very rare in the Asian races as well. I don't think that occurs at all. It's really debilitating to people when they get these contractions of their fingers, and it's a bit like my hair loss. I like to liken it to my hair loss. All right, it's congenital. Okay, I'll just shave my head for this example. So it's congenital. If I go and have a hair transplant, another part will fall off because it's all part of the genetics. So you can release a contracture of the Dupuytren's, but it can come back. Okay, so why do you do surgery on it? Well, when it's debilitating and causing issues. So if it's just a hand that has a lump there, don't mess around with it, because you can cut it out. You can come back. It can come back with vengeance and be even worse. But if they're getting a contraction, they're poking themselves in the eyes every time they wash their face, or they can't get their hand in their pocket, or they're skinning themselves every time to try and get letters out of the letterbox. You know, it's real annoying to them. But of course, this tissue wraps around the nerves when you do it, so it has to be carefully released. So it actually does take an hour and a half or so to actually do proper Dupuytren surgery. And it's all genetics, and it will come back at some stage. If they live long enough, it will play out at some stage. Some don't, you know. Some have got slowly progressing ones that might have taken 70 years to develop, and it might need another 70 years to come back. But some come back with vengeance. There's more in the ladies. It's actually, if you get it in a lady, it's even a more bad version of it. So it's not alcohol as much. You can speak to Chen about the exact causation, whether it's still associated. I don't consider it as, but I think there may still be an association with it. There may be some association with. It's either less common in epileptics, I think, because of the medication they use, and there's all these other associations, but the main one is genetics. Okay, and that's definitely a cause. And then we've got, just remembering this, if you fall on your wrist, and you can actually not only break the bone, dislocate the joint, but the ligaments between the radius and ulna can be disrupted, the triangular fiber cartilage, and that can lead to ulnar-sided wrist pain. So when it comes to seeing someone, okay, trying to tie it all together, okay, they come in after trauma, and they've got a history of that, like the lad who fell over playing footy, history of trauma, we're thinking of a fracture, okay, or a dislocation. We find where they're sore. If it's on the radial side of the wrist, we're thinking, is it the radiostyloid, is it scaphoid, is it the base of the metacarpal, or is it the scapholunate region, okay? So on the ulnar side of the wrist, we're thinking maybe the triangular fiber cartilage tear, maybe the base of the fifth metacarpal, okay, or the triquetrum with the ligaments avulsed, or maybe even the pisiform splayed up, okay? If it involves the phalanges or the fingers, it's pretty obvious, isn't it? You can see the deformity in that area, okay? If they've had a laceration, we think of the structures that could be damaged. We look at FTP and FTS, and we're coming on Tuesday when they go through it, but you look at with the FTP flex of the proximal phalanx, so FTS affects the proximal phalanx, FTP the distal phalanges, okay, or the extensors, okay. We look at, is there a nerve damage? We look at sensation in the hand. And we can check circulation as well. Does everyone know Allen's test at all? You heard of Allen's test, where you compress the radial and the ulnar arteries together, make a fist, you compress the radial and ulnar artery, and you open it, it should stay a bit white, and then you release one of them, and it goes pink. And you do it again, you press the radial and ulnar artery and open it, and then release the radial artery and it goes pink. See, mine's a bit slow, I'm more ulnar dominant on my hand. So So you can press those too. So, all right. But of course, if there's been a penetrating injury, we think of what could be damaged, like a punch injury, or if there's been a stabbing. We think of risk of infection. We think of the nerve. We think if there's been a laceration, we think of the tendons and nerves will be damaged in that way. So that's our traumatic presentations. Okay. Remembering that spontaneous infections can occur, but usually it's after a penetrating injury in the hand. The reason spontaneous infections are less common, I mean, they can occur after infections around the fingernails, of course, but the reason they're less common is it's got such good blood supply to the hand that it actually, any body's ability to fight it and destroy the infection is so much better, okay, around the hand, because the blood supply is getting to the areas with poor blood supply, greater risk of infection. Now, I know the scapula, we talk about the scapula having poor blood supply, but still, in the soft tissues, there's still good blood supply. It's just in that particular part of the bone, it's poor. Okay. Right. It comes in with elective conditions. Is it a neurological condition? Carpal tunnel is the main common, but it could be ulnar nerve, could be referred for the neck. Okay. Is it a bony condition? Is it arthritis? Is it a tendon problem, or is it one of the unusual things to think of, the extra ones? Okay. So, when it comes to what you need to know, there's a fair bit to know, but really, it's you can break something, and which bones you break, you need to know your anatomy, but you should know your anatomy pretty well. You remember your mnemonic, that one, which is probably hard to forget now if you know, and or other ones as well. Okay, so you remember your tendons and nerves that affect. There was only 3 nerves that involve the hand, or 5 really, if you branch the median nerve into the anterior interosseous and the median proper, and the radial into posterior interosseous and radius. And you need to know the tendons that can occur, which are not that hard. You need to know the retinaculums to be caught, but I mean really the first one, the most important one is the first ascending compartment, because that can cause the Quervains. The dorsal compartment can lead to tendonitis, and maybe knowing the ECU tendon over the ulna, which is the 6th compartment, can cause pain as well. Okay, they're the main ones. Okay, you need, and that's really all there is to know. So that divides the conditions into a sort of summary. You probably, if I was learning from scratch, it might take you an afternoon to go through all that, or 2 or 3 hours. But really, it's the hardest part of orthopedics. But I reckon if you go through, use this as a background to what to learn from, I think you've covered most of the hand conditions. Now, there won't be everything in there, okay? I'm sure there'll be one I can think of. You might be able to think of something they haven't put in there, and we add to it. But really, that's the bulk of what you need to know. All right, and that's on my website if you need to grab that. It'll just downloads from there.